Now let's take a look at the spinal nerves. Instead of 12, there are 31 pairs of spinal nerves. These are all mixed, and they're named for the point of issue off the spinal cord. They supply all body parts except for the head and part of the neck. There are 8 pairs of cervical nerves, 12 thoracic, 5 lumbar, 5 sacral, and 1 pair of coccygeal nerves. So that 8, 12, and 5 should remind you of the number of vertebrae in each of those regions as well. So there's 7 cervical vertebrae, actually give rise to 8 pairs of cervical spinal nerves. Each of the first 7 pairs exit above the vertebrae from which it's named, and the last spinal nerve exits the cranial canal below C7. So vertebrae C7 has a nerve that leaves above it and one that leaves below it. The rest have all that leave above. Each of the other spinal nerves goes inferior to the vertebrae from which it is named. And here they are mapped out for you in 13.7. Each spinal nerve is connected to the spinal cord through 2 roots, a ventral root and a dorsal root. The ventral root contains the motor or efferent fibers from the ventral horn motor neurons that innervate skeletal muscles, while the dorsal root contains sensory or afferent fibers from sensory neurons in dorsal root ganglia that are conducting impulses from the peripheral receptors. Both the ventral and dorsal roots are branched medially as rootlets, and then they join laterally to form the spinal nerve, as shown here. Spinal nerves emerge from the vertebral column through their respective intervertebral foramina, and those spinal roots become progressively longer, superior to inferiorly down the cord, so that lumbar and sacral roots are very long and extend through the lower vertebrae canal as a structure we've talked about before called the cauda equina, Latin for horse's tail, which is what it looks like. Spinal nerves are quite short, 1 to 2 centimeters, and they almost immediately, after exiting the foramen, divide into branches, a dorsal, ventral, and meningeal. The dorsal and ventral are called rami. The dorsal is the smaller, the ventral is the larger, and the meningeal are tiny branches that re-enter the vertebral canal, innervating meninges and blood vessels. Their structure is called the rami communicantes, which contain autonomic nerve fibers joining the ventral rami in the thoracic region, as shown here. Specific body regions, the spinal nerve rami and their main branches supply the entire somatic body region from the neck down. Dorsal rami supply the posterior body trunk. Ventral rami supply the rest of the trunk and the limbs. The main differences between roots and rami: roots lie medial to and form spinal nerves. Rami lie distal to and are lateral branches of spinal nerves. So roots are part of the spinal nerve. Rami are branches of the spinal nerve. Root is either sensory or motor. Rami can carry and do carry both sensory and motor. All the ventral rami except T2 through T12 form interlacing networks called nerve plexuses. They're found in the cervical, brachial, lumbar, and sacral regions. Ventral rami form those plexuses. Within a plexus, fibers crisscross so that each branch contains fibers from several different spinal nerves. Fibers from the ventral rami go to the body periphery through several roots. That means that each limb muscle is innervated by more than one spinal nerve, so damage to a single nerve would not cause paralysis. The cervical plexus and the neck, the first 4 ventral rami form a looping cervical plexus. Most of its branches form the cutaneous nerves, which innervate the skin, the neck, the ear, the back of the head, and the shoulders. There are other branches that innervate neck muscles. The phrenic nerve is a major motor and sensory nerve to the diaphragm. It's a major muscle for breathing. And the phrenic nerve receives fibers from C3 to C5. Irritation of the phrenic nerve causes spasms of the diaphragm, which are commonly referred to as hiccups. If both the phrenic nerves are severed, or if C3 through C5 region is destroyed, the diaphragm becomes paralyzed, leading to respiratory arrest. Patients would then require mechanical respirators to remain alive, and a mechanical respirator would mechanically force air into the lungs, so literally breathing for the individual. Brachial plexus in the upper limb, formed by the ventral rami of C5 through C8 and T1, gives rise to nerves that innervate the upper limb. It has four major branches: the roots, trunks, divisions, and cords. So the roots would be the five ventral rami uniting to form the trunk. The trunk would be the upper, middle, and lower, which are going to unite to form the division, anterior and posterior, and they will unite to form the lateral, medial, and posterior cords, as shown here. Cords of the brachial plexus give rise to nerves of the upper limb, the five most important being the axillary, musculocutaneous, median, ulnar, and radial. The axillary innervates the deltoid, teres minor, and the skin and joint capsule of the shoulder. The musculocutaneous innervates the biceps brachii, brachialis, coracobrachialis, and the skin of the lateral forearm. The median innervates the skin, most of the flexors, forearm pronators, wrist and finger flexors, and thumb opposition muscles, while the ulnar supplies the flexor carpi ulnaris, the flexor, part of the flexor digitorum profundus, most of the intrinsic hand muscles, and the skin on the medial aspect of the hand, as well as wrist and finger flexion. And the radial innervates essentially all the extensor muscles, supinators, and posterior skin of the limb. There's our brachial plexus. Injuries to the brachial plexus are common. Severe injury can weaken or paralyze an entire upper limb. Injuries can occur to the limb that's pulled too hard, stretching the plexus. For example, when a football tackler yanks the arm of running back, or a blow to the top of the shoulders, which can force the humerus inferiorly. Injury to the median nerve makes it difficult to use the pincer grasp. That's the opposition of thumb and index finger to pick up small objects. And that can be seen in carpal tunnel syndrome when the median nerve becomes compressed. It is also frequently a casualty of individuals who try to commit suicide by slashing their wrists. Ulnar nerve is very vulnerable to injury. Severe chronic damage to the ulnar nerve can lead to sensory loss, paralysis, and muscle atrophy. Affected individuals would have trouble making a fist and gripping objects. Their little and ring fingers would become hyperextended at the knuckles and flexed at the distal interpharyngeal joints, which would cause it to have what we would refer to as a claw hand. And interestingly, striking the funny bone, that's the spot where the nerve rests against the medial epicondyle, can make your fingers tingle. It's important to know that the funny bone is neither funny nor a bone. It's a blow to the ulnar nerve. And there's that claw hand. Trauma to the radial nerve can result in wrist droop, the inability to extend the hand at the wrist. Improper use of a crutch can compress the radial nerve and impair its blood supply. We also have possibility for Saturday night paralysis, when an intoxicated person would fall asleep with an arm draped over the back of a chair or sofa, cutting off supply to the radial nerve, and that would give you this droop. Lumbosacral plexus in the lower limb. The lumbar and sacral plexuses have significant overlaps. Fibers from the lumbar plexus contribute to the sacral plexus via the lumbosacral trunk. The lumbosacral plexus serves most of the lower limb, but also sends branches to the abdomen, the pelvis, and the buttocks. Rises from L1 to L4, innervates the thigh, the abdominal wall, the psoas muscle. The femoral nerve is going to innervate the quadriceps, skin of the anterior thigh and medial surface of the leg, while the obturator nerve would pass through the obturator foramen and innervate the adductor muscles. Sacral plexus from L4 to S4 serves the buttocks, the lower limb, pelvic structures, perineum. It has the sciatic nerve. The sciatic nerve is the longest and thickest nerve of the body, which innervates the hamstring muscles, the adductor magnus, and most of the muscles in the leg and foot. It's got two nerves, the tibial and the common fibular. Spinal roots and lumbar plexuses are compressed. Gait problems can occur. Other symptoms are pain or numbness in the anterior thigh. Femoral nerve damage, serves prime movers that flex the hip and extend the hip so that damage can be caused by a herniated disc. If that obturator nerve is impaired, the person would experience pain in the medial thigh. Sciatica is a common problem, as stabbing pains radiating over the course of the sciatic nerve could be caused by a fall, disc herniation, badly placed injection into the buttock. If the nerve is transected, the leg becomes nearly useless and cannot be flexed because the hamstrings become paralyzed. Foot and ankle can't move at all, so the foot droops into plantar flexion, a condition called foot drop. And recovery from sciatic nerve injury, like most nerve injuries, is slow and typically incomplete. For lesions that are below the knee, the thigh muscles are spared, but if tibial nerve is injured, the paralyzed calf muscles can't not plantar flex the foot, and a shuffling gait would develop. Anterior lateral thorax and abdominal wall, so the ventral rami of T12 through T12 are intercostal nerves that supply muscles of the ribs. I believe that should be T1 through T12, and give off cutaneous branches along the course. It has two special thoracic nerves, T1, which is very tiny, and T12, which is the subcostal nerve. The back is innervated by dorsal rami via several branches, and each branch innervates a strip of muscle and skin in line with where it emerges from the spinal cord. Which brings us to a discussion of innervation of the skin. And innervation of the skin leads us to structures we call dermatomes. Dermatomes are areas of the skin that are innervated by cutaneous branches from a single spinal nerve. So all the spinal nerves except for C1 participate in dermatomes. Extent of a spinal cord injury, therefore, can be ascertained by its effect on those dermatomes. Most dermatomes overlap, so destruction of a single nerve will not cause complete numbness. But if we map them out, we can see which regions are covered by which nerve. Joints, remember the nerve serves a joint, synovial joint. We're going to use Hilton's law so that any nerve serving a muscle that produces movement at a joint also innervates that joint and the skin over that joint. And that brings us to the end of the spinal nerves.